Hi, my name is Arzu Farhangi and I'm from University of Miami JFK Medical Center and I'm talking about the rare case of Rhupus syndrome presenting with multiple acute strokes. We report an unusual presentation of Rhupus syndrome, a rare association between rheumatoid arthritis and SLE. The patient presented with acute encephalopathy secondary to multiple acute strokes precipitated by hypercoagulable state due to a concomitant antiphospholipid syndrome. The case is a 62-year-old African-American female who presented to the ED with a one-week onset of altered mental state, weight loss, and generalized ache and muscle weakness. Upon presentation, the patient did not follow commands nor answered orientation questions appropriately. Vital signs were abnormal with tachycardia and temperature of 102 Fahrenheit. On physical exam, she appeared cachectic, heart rate was rapid and regular. On musculoskeletal examination, reversible MCP subluxations, Jacob's arthropathy, boutonniere deformity in both hands, and trace synovitis of both wrists were noted, as you can see in Figure 1. Laboratory testing was notable for elevated inflammatory markers such as ESR and CRP and elevated D-dimer. Direct antiglobulin and Coombs tests were also positive. Rheumatological serology testing revealed an elevated ANA, anti-Smith, chromatin SSA, RNP antibodies, rheumatoid factor, and CCP, and low level of C3 and C4. MRI of the brain demonstrated multiple areas of small acute strokes involving the pons, right cerebellum, and bilateral basal ganglia, as you can see in Figure 2. CT angio of the chest was negative for PE, and echo was also normal. She was started on intravenous methylprednisone 80 mg Q8 hours during her hospitalization with partial improvement in her mental state and generalized pain and weakness. Anticoagulation was also initiated on hospital day 16. She was discharged on oral prednisone 20 per day and also apixaban. In discussion, the coexistence of lupus and RA named Rhupus is an unusual clinical condition. Several studies have shown that Rhupus patients have an increased prevalence of positive antiphospholipid antibodies that resembles SLE. There is only one case of Rhupus with secondary APS in which the patient presented with headache and papilledema due to cerebral venous thrombosis. Laboratory findings such as anti-CCP antibodies, anti-double-strand antibody DNA, and anti-Smith antibody positive are diagnostic criteria for Rhupus. A high titration of anti-RNP antibody is very important in the overlap syndrome diagnosis. The most commonly reported clinical manifestation in the cases of Rhupus are the presence of erosive polyarthritis, rheumatoid nodules, malar rash, photosensitivity, alopecia, and presence of constitutional symptoms. Renal and neurological involvement are more rarely described. In this patient, the erosive polyarthritis appeared as a predominant form of RA, whereas the manifestation of APS, hypercoagulable state, and multiple acute strokes were those of greater clinical significance. In conclusion, physicians should be aware of the possibility that lupus may be accompanied by progressive or life-threatening conditions such as APS and thrombotic events such as a stroke. Thank you for your attention.